Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and I am so glad to be back in the Sunflower House. And joining me today on this special podcast is Dr. Stetson Thacker, and he's, of course, of no relation to me. Yes, he is my oldest son. I know you've heard about him a lot in the first season on my previous podcast episodes, and if you haven't caught season 1, please be sure to go back and listen to some of them. Stetson is the father of Artemis and Beatrice, my two lovely granddaughters, and he is the husband to Laura Thacker, who's a nurse practitioner. So I'll give you a little bit of bio, and you'll have to indulge me as a mother. Stetson completed a PhD in genomic medicine at Case Western Reserve University and the Cleveland Clinic Lerner College of Medicine Research Institute. He had a bachelor's in biology and English and a minor in chemistry, and only a mother would know that. He actually wanted a triple major, and I said enough is enough. He was an author from a young age at 17, publishing Poetic Pondering, a Transcendental Odyssey. So he definitely has the heart of a poet. He's also a fitness enthusiast and had a lot of athletic awards in high school, including one of the top 25 in the country Got Milk athlete scholars. He won a lot of state and other national awards. And during high school, he did hundreds of hours of volunteer work and also was a Cleveland Clinic science intern, which I think piqued his interest in genomic medicine. And I've already warned him he has to kind of keep his answers understandable to me and our national audience. So he studied in his PhD the impact of genetic variation on protein structure and function, and clinical traits in cancer syndromes, including a syndrome called P10 hamartoma tumor syndrome, PHTS. So right now, today, Stetson works to improve utilization and interpretability of next-generation sequence assays, specifically molecular diagnostics, for cancer patients. And this involves designing, testing, and supporting precision oncology applications for pathologists, physicians, oncologists at Genome Oncology. And in his free time, he writes on various subjects, including cancer genomics on Substack, and his Substack is stetson.substack.com. Very few people can just go by their first name, and I think he probably has his mother to thank for that. Welcome, Stetson.
Thank you. Nice to be with you, Mom.
And it's certainly a pleasure to have you here. And we'll talk about your PhD and your science background. And also I would like to go a little bit into your fitness interest and your interest in literature. And we want to also talk about some of the great columns that you authored when you were doing your PhD at Speaking of Women's Health. And for any of our listeners who have not bookmarked speakingofwomenshealth.com, please do that. And several of these topics that we're going to talk about, you can get more information on our website. So, Stetson, share with us what you studied while getting your PhD.
Yes, yeah. I did my PhD work at Case Western Reserve with a dual program with the Cleveland Clinic at the Lerner Research Institute. And I was supervised by Dr. Karasang, who's a world-renowned expert in the gene P10. And the gene is called P10 because it's found on the 10th chromosome, and it's a phosphatase. That's a type of protein. So P10. It's the gene name rationale there. And I studied the impact of the clinical impact of variation in the gene. So people can inherit different types of mutations in the sequence of this gene. They're very rare. It's only about 1 in 200,000 people that this happens to. But people who have these mutations, they have a variety of different traits. They can have cancers, they can have neurodevelopmental issues like big heads, autism, epilepsy sometimes, and there's also a lot of other features like certain changes to the skin and other distinctive features, some of which can go under the radar. So a lot of the times this condition that is associated with PTEN mutations, which is called today PTEN hammer-tumor syndrome, but can also historically was often called Cowden syndrome, can be missed sometimes in the clinic. So it's why we have experts and specialists like Dr. Eng who know what to look for and have a deep understanding of the disease. But in trying to understand the mutations in PTEN, we used a lot of different types of data from cell lines, animal models, some high throughput DNA and RNA sequencing assays, as well as specialized multiplex experiments called deep mutational scanning assays. And we, pulled all this data together, and we were using it to try to figure out what the functional impact of the variants were and whether they correlated in any way with outcomes in the clinic. Because there are so many traits associated with these PTEN mutations, we want to know, do certain mutations go one way and do other mutations go another way? And to some extent, the answer is yes. It's not it's a very complex picture, but we found that mutations that didn't quite completely destroy the function of PTEN, they allowed some PTEN activity to remain, were slightly more associated with the neurodevelopmental features versus the cancer overgrowth features that are otherwise observed in these Cowden syndrome patients or PTEN hammer-tumor syndrome patients.
Well, even though it's only 1 in 200,000, I have several Cowden patients in my practice, in part because we see a lot of high-risk cancer patients in our Center for Specialized Women's Health, and of course because of the very impressive Dr. Karis Eng, an MD, PhD, a geneticist cancer researcher, and so several are on referral from her huge program. I remember, of course, when you discovered that Dr. Eng had a Wikipedia page and I didn't, and you let me know that. But she is so impressive, and I'm sure your experience with all the scientists and the bench researchers and also the clinical exposure that you got helped formulate some of the things that you're working on now. So tell us some of the things what you're doing now and what you work on a day-to-day basis, especially related to cancer and cancer diagnosis and individualizing things, because everyone knows someone either in their family or friends who has cancer, and that is one of the leading causes of death.
Yes, so today I work for a startup software / biotech company named Genome Oncology, which is a portmanteau of genome and oncology. So smash those together. And Genome Oncology is a company that makes applications, software, to support pathologists and oncologists when they're making clinical decisions for cancer patients that have molecular profiles. And these molecular profiles come from these molecular diagnostic assays, which are built on top of advanced sequencing technology. And that's DNA sequencing. Your genome is composed of 3 billion base pairs of DNA. So it's very big. And it took many years to figure out the sequence of the genome. It was, there was the major Human Genome Project, which, wouldn't have finished on time if not for a lot of major advancements. And out of the Human Genome Project era, there was subsequent advancements in DNA sequencing that now allow DNA sequencing to be done quite cheaply. We're approaching an era where it only costs around $100 or so to get a whole clinical grade genome, which means you've sequenced every one of those 3 billion base pairs times 2 at a depth of 30 reads or more. So it shows you how fast DNA sequencing has advanced and how cheap it's become. And so we a lot of times in patients who have advanced cancers, they are referred for this DNA sequencing of the tumor itself, or sometimes just of a sample of their blood, because a lot of times tumors will shed cells and DNA, and that can be captured by these assays because they're very sensitive. And so this creates a lot of data when you run one of these assays, and they have to be interpreted. And genome oncology builds tools and has a platform that sits at the very end of this process that helps the molecular pathologist interpret the results that they see, the variants that they find, the mutations they find, and then also report them, generate a report that then can be delivered to an oncologist and the patient, and help them understand what therapies would be best for this patient that are precise and targeted for the type of cancer that they have, and what trials, if there are no therapies available, could they be matched to, so that they could join a clinical trial to potentially be treated with an investigational agent.
So
this is generally what genome oncology is doing.
So being on the leading edge really helps. And I think in the past, a lot of people thought that certain cancers were a death sentence. And many people are living long, productive lives, even when they're diagnosed with metastatic cancer. So what are some of the cancers that there's been really some dramatic changes in just the last few years?
We'll be back after a quick break.
Are you ready to unlock your full potential? I want to introduce you to the Fit, Healthy, and Happy podcast, a powerful resource to transform your life today. With expert interviews, practical tips, and inspiring stories, this podcast is your roadmap to lasting wellness. Here's what a listener has to say.
I used to struggle with my health, but this podcast changed everything. It's like having a personal trainer, nutritionist, and life coach totally for free.
With over 2,000 five-star reviews, we're a podcast you can trust. The Fit, Healthy, and Happy podcast, available now wherever you get your podcasts.
Yes, I think one of the great examples of where sort of the precision medicine era has had very clear benefits is in non-small cell lung cancer.
Yes.
So it's a specific type of lung cancer, but it's the major type. And there are at least 7 known biomarkers or genes that have known alterations that can drive non-small cell lung cancer. And those can be targeted with FDA-approved agents. And, so it's really changed some of the outcomes in a lot of these cases. For instance, a lot of these patients with this type of lung cancer, they have mutations in a gene called EGFR. And there's now a drug that targets these mutations in EGFR called osimertinib. It's actually a third generation of this EGFR inhibitor, and it's shown to be very effective and improve the lives. And in fact, they've recently shown that the earlier you find that these patients have these mutations and the earlier you treat them, the more likely you are to improve their survival outcomes. And this, if you have this mutation, you get to be treated with this drug instead of potentially getting, very damaging and chemotherapy and radiation of side effects. And a lot of times you don't necessarily get to avoid that altogether. Sometimes these are tacked on along with those, along with chemo radiation, but we're still showing improvements in survival outcomes in that case. Another great successful example is in melanoma, which it's not so much with the targeted inhibitors, but with a new class of drugs called immunotherapy. And these immunotherapy drugs, they basically get the immune system to attack the cancer in your body, and these new agents have really dramatically improved survival outcomes in melanoma, pushing the 5-year survival rates up over 90% in some cases.
And so some of the more successful diagnostics in terms of doing genetic testing for risk assessment with cancers has been in the women's health area in terms of the breast and ovarian cancer genes. And there are some new agents, as I understand, that are specifically helpful in those patients that are BRCA positive.
Yes, yeah. So if you're a patient who carries a BRCA mutation, a lot of times you then become eligible for a class of drugs called PARP inhibitors. And there's different PARP inhibitors that have been improved, and the settings in which they're an option, can vary. But like an example of a PARP inhibitor that may be familiar to some people is olaparib. There's also rucaparib, and so there's these options, and they can also be targeted agents that get tacked on along with chemotherapies as well. But those are drugs that are options for those who carry BRCA mutations.
And Dr. Holly Peterson, who was on the podcast on breast and ovarian cancer and some controversies, she and I were kind of having an interesting discussion and some sparring back and forth with our different perspectives. She had mentioned the PARP inhibitors being such an advance. And she was also making the point about recreational genetic testing, which of course some members of our family have done, as opposed to medical genetic testing.
Yes.
So do you want to expand a little bit about that, since you've had expertise in both areas, recreational and medical?
Well, yeah, I don't know I have experience in recreational testing. I don't know if I have expertise per se, but they're very different tests. So if you take one of these direct-to-consumer ancestry genetic kits, are sold by 23andMe or Ancestry.com, just to learn more about, your ancestral background, and maybe it gives you some information on certain traits like, your hair color or your, and such things. These actually test what are called polymorphisms, which are areas of the genome that are known to vary sort of naturally between people, and they're not variants that are associated particularly with disease. I mean, some of them may contribute to disease, but in such a tiny way that they're not something that natural selection would select against. So they look at these little points, and they're not looking at the genome in a very detailed way, whereas a clinical assay is looking at the genome in a very detailed way down to every single base pair. So there's a difference essentially in resolution and depth between these two assays. They're based on different technologies. So in no way would these direct-to-consumer tests at this time be of medical grade. There's other complexities involved as well, for which you wouldn't want to just trust an Ancestry direct-to-consumer kit as a medical grade test, just because there's a lot of different analysis and validation that goes into putting together an in vitro diagnostic that's made for medical purposes.
I think that's so important, because a lot of people, if they have a family history of cancer and they've had 23andMe and they're told that they don't, have BRCA genes, they're only testing for a few, and that's only valid, as I understand, in people of Ashkenazi Jewish ancestry. And there's several other genes. And then there's also, and so when you're talking about the polymorphisms, you're talking about maybe smaller genes as opposed to like big genes that we think of, or intermediate genes in terms of
No, a polymorphism, it's referring to one base pair of DNA, and it could be anywhere in the genome, and it's just these base pairs are chosen because they're what are called ancestry informative markers. So these companies have done sampling of contemporary populations that they know have lived in certain areas for a long time, and then they've done genetic analyses to associate the little base pairs that they've genotyped, and shown that they have a different profile in one area versus another area. And then they look at you, the individual, and see what your profile looks like relative to those known existing profiles. Mm-hmm. And that's, so they're not typically, like if you're just looking for the polymorphisms that are related to ancestry, they can't necessarily provide any information in a medical level. Now, the 23andMe has then tacked on 3 specific markers that aren't just polymorphisms; those are mutations that cause disease. But they only look at 3 in the BRCA gene, and those 3 are known to be common in Ashkenazi populations, which has to do with the unique history of Ashkenazi Jewish people. And those are what are called founder mutations. So founder mutations, this is population genetics, have to do with, how a population is formed, and they are mutations that are common to a population, but they really shouldn't be in terms of if situations weren't as special as they are in that case, if that makes sense.
And I think that the FDA just recently approved 23andMe to do more genetic testing, but again, it's not medical grade. Do you have any opinion about? I know just in clinic the other day, one of our fellows was talking to a patient who wanted to have medical grade genetic testing, but insurance wouldn't cover it. And she was talking about going to Invitae.com and getting a full medical genetic testing for like $250. As someone who trained, amongst clinical geneticists, and you've seen what goes into genetic counseling. Do you have any perspective on that? Whether people should just go and do that on their own, or whether they should only do it through a physician or through a genetic counselor?
Personally, I'm of the position that, more information is better.
Yes.
But of course, I have a background and expertise in genetics. So someone who maybe doesn't have that background, maybe more information in those cases may not be better. But, Invitae does make clinical grade molecular diagnostics. For instance, they have a panel that just was approved by the FDA to screen for hereditary variants in cancer genes. And it's a blood test. So they take blood from you, and then they would run the test, sequence your DNA, and look for if you have mutations in any of the genes that have validated associations with cancer phenotypes. Now, the challenge, though, of this is that there's still many variants that we don't understand what the effects of those are. And those, in the clinical speak, are called variants of unknown significance.
Yes, VUS.
And there's a lot of controversy about, the VUS, about, how they should be reported, whether they should be reported, what do they mean. There's a lot of confusion or frustration that is of concern when communicating these results to lay individuals. And especially if they, have a family history or if they have disease, it can be, really complicated, because it'd be like, well, that's got to be it. Or like, do I have risk, if they don't have something? So there's a lot of complexity. So if you do choose to get a genetic test, I think it is wise to get some form of genetic counseling or speak with a medical professional who's an expert in genetics officially. Now, if insurance won't cover the test, but you think it's still good to get the test, then, and it's affordable, then I think it's worthwhile to do. It's also good to have a professional to work through the results with, especially if and when they're ambiguous. In some cases, it's very clear. In other cases, it's not. So.
I would definitely endorse that. Well, you have been listening to the Speaking of Women's Health podcast with me, your host, Dr. Holly Thacker, and I'm interviewing Dr. Stetson Thacker, who has his PhD in genomic medicine. No relation to me, as I like to joke. We're going to shift gears a little bit and talk about some of the great columns that you've authored on speakingofwomenshealth.com. Especially since we're in season 2 and, we're all just still hopefully sticking to our New Year's resolutions, which a lot of times have to do with health and fitness. And you've certainly been an athlete and a fitness enthusiast for most of your life. You did a nice column on protein supplements and shared some helpful advice on losing weight in a healthy, sustainable manner. I know you made a comment to me a while ago about some of the new obesity medications, and you said in 30 years we're not going to have any more obesity, and that kind of floored me. Tell me why you think that.
Well, so we're referring to the GLP-1 agonist class of drugs, which include agents like semaglutide and tirzepatide, and they have been shown to very effectively reduce weight. I think as much as up to like 25-30% of body weight loss, and over the course of a year and a half or so. and they're very durable as long as the drug is continued to be used. But maybe my statement was a little strong. I'm not sure necessarily that we would never have any obesity whatsoever. Of course, in some cases, obesity is a genetic condition.
Yes,
So
rarely. Yes.
I'm not sure if GLP-1 agonists would actually work in some of those genetic conditions or not. I don't know if there's any data available on that. However, I think the total burden of obesity and obesity-related conditions, I think, can be significantly impacted by this new drug class, especially because, we've had some effective weight loss drugs in the past, but the side effects, adverse events related to the use of those drugs was too severe to tolerate, whereas these GLP-1 agonists, despite, of course, having some side effects like nausea and so on, don't have the more serious side effects that were observed in the past with other weight loss agents. So I think they're very tolerable agents, and they can be used for as long as possible. And they seem to work. They seem to have multiple mechanisms of efficacy, not just to work through, by slowing down the gut, which is typically a lot of times how they talk about the effectiveness of the drug and making people feel satiety earlier in the course of a meal, but also potentially by improving our executive function and preventing people from, indulging themselves and snacking when they shouldn't be eating and such. There's, not necessarily a complete description of this mechanism, but there seemed to be some evidence of this already, given that some people are reporting now that they have, less urge to drink alcohol, are engaging in, less impulsive behaviors when on these GLP-1 agonists. And maybe the limitation is this, what the indications are currently approved for right now, but I expect this to expand, and then also the cost of the drugs, which are quite high.
When I started this podcast last year in 2023, I did a series of medical CME and interviews. So for the physicians listening who wants free CME, you can certainly go back and listen. And we were talking about these small molecules that affect a part of the brain that senses temperature regulation. And so I think a lot of these molecules not just affect temperature sensation and hot flashes, which of course is of quite interest to me in my practice, but also satiety and other feelings, perception of pain, and other factors. So I think this is going to be a really big field in the future with a lot of advances. At our recent Center of Specialized Women's Health meeting, I invited a medical director of weight and bariatric medicine, Dr. Winfield Scott Butch, and he was talking about he's doing a trial right now with an investigational agent that has 3 mechanisms of action. So not just the GLP-1 and also the other effects that teriparatide has, but a third one. But patients have to have a high BMI and active vascular disease. So I'll be keeping an eye on that trial and referring people. But getting back to some basic things that all of us can focus on, walk us through the comprehensive weight loss plan that you discussed in your column when you talked about calculating total energy and various equations and activity factors.
Sure. Well, it's been a while since I've written that column, but I think that the general idea is that, if you calculate your total daily energy expenditure as a given individual, which has a lot to do with how much lean mass you have as an individual, because that tends to affect, how many calories you're going to burn in a given day. If you are able to calculate that accurately, which can be a bit of a challenge, you have to assess your body fat, and then you have to do some basic calculations. Of course, calculators for this are available on the internet. You can probably get a reasonable estimate by, this making some reasonable assumptions. If you are able to calculate your total daily energy expenditure, and then construct a diet plan that allows you to eat, 10 to 15% less calories than your total daily energy expenditure, you should be able to achieve durable weight loss. Now, it's the question. The challenge is there is making sure that you're assessing exactly how many calories you're eating accurately. Which, if you're really going to be persnickety about it, includes like potentially weighing your own food. And doing a lot of these things, that people aren't in their normal life going to be able to achieve. But if you can shoot for this reasonable heuristic and have, some of the self-control and discipline to achieve it, weight loss is certainly within reach. There's a lot of kind of noise about weight loss not simply being a calories in, calories out sort of deal. And in reality, it, for the most part, and for most people, it really is a calories in, calories out deal. It's just that the layer of being able to control our own behavior and control our environments is the major limitation. And we can't necessarily totally control those things. And that's why the GLP-1 agonist, if it indeed works by, in some cases, behavioral modification, is such a, such a great thing, because that's really what I think a lot of us struggle with in terms of being able to achieve durable weight loss.
Well, certainly I think that age plays a role, because people with each successive decade have a slower metabolism, and after 45 you can have sarcopenia and lose muscle mass, which contributes to your basal metabolic rate. I also think that the older you get, it's slower for your gut hormones and neurotransmitters to feed to your brain that you've eaten enough, because I've had the experience of feeling like I ate just the right amount, and then 30 or 40 minutes later, like, oh, it's too much, because it took too long to get that feedback. And so that's why one of the tips I give people is just only eat till you're about 80% full. Try to use smaller plates. And then if you're hungry in 30 minutes, go back and get something. And certainly I think that's why children eat such little bits, and they want to eat throughout the day, like toddlers, like your daughter, who likes snacks. Can I have a snack, Mimi? A snack. And of course you and your wife want her to have a regular meal and sit there and then ask to be excused, which is so cute. So one of the things I learned about you from you in the protein column, because I see a lot of women with tendinitis, and certainly a subset of women postmenopausally estrogen deficient, and even when I was not postmenopausal, but I was post-delivery after having you, which is a low estrogen state postpartum, had terrible tendinitis, both my hands and splints. And you told me that whey protein is the only protein that really helps with tendon repair. So talk about some of the basic proteins, where people can get protein from, and how eating macronutrients for weight loss may help.
Yes, and this isn't necessarily like a extremely robust clinical finding, but I think there's good like preclinical evidence and maybe some small cohort studies that show that ingesting a good amount of whey protein definitely improves muscle protein synthesis, but also can help with tendon repair and growth as well. And it just can be very challenging to sometimes get enough protein in our diet in a way that is easily digestible without eating a giant steak or something like this. And also just you get a lot of other macronutrients along with that, like fat, saturated fats, and so on. So a whey protein powder is if you get a very high grade one, is essentially almost just a pure 40-gram scoop of protein that you can throw in water and drink down in a few minutes, and it's a good way to get protein that way. And a lot of times it can help you feel more full. So in some cases it will help you snack less in between meals, or eat less at a meal. And one of the reasons why this may be has to do with the fact that whey protein, while having all of your essential amino acids, is especially rich in what are called branched chain amino acids, which are known to be especially important in processes like muscle protein synthesis.
And as an avid exerciser, you certainly built a lot of muscle, and I find it amusing how all three of my sons have obesity listed under their BMI, which just goes to show the body mass index calculation's not always accurate in terms of body fat. And so you do want to have a high muscle mass. It's just that you don't want to have excess visceral fat, especially fat in the abdomen and the apple-shaped weight, and fat amongst your organs. So your body fat analysis, which you've done several different ways. You want to talk about how you can assess what your lean body mass is, how you've done that.
Yeah, the simplest way that I've had the body fat calculation done, it was just the 7-fold skin test, which is essentially with calipers, where they're checking at various points over your body and measuring, how much fat is there. But there's also a DEXA scan that can be done to analyze how much fat you have as well. And there's some variability between those numbers for me, but those are the two ways, at least I personally had it done. There's a few other methods. I believe the submersion method
yes,
is actually considered, I guess, the one with the most accuracy, I think. But I think if you have it done a few different ways, I think you can get to a general idea of what your actual number may be, because it does seem like there's some variation between them.
Yeah, I do think the total body analysis, which I've done on my bone density machine, which looks at soft tissue and bone, is very accurate. It's certainly done by athletes and done in various nutritional studies, and I've certainly scanned you. It's generally not covered by insurance and expensive. The submersion one's interesting. Our guest podcaster Sylvia Morrison, who is always writing down what she eats and always exercising at least once, if not twice a day, went and had the submersion assessment done. I think for exercise, a lot of people come to see me as patients and they're frustrated because they're exercising regularly and they're not losing weight. And really, I think exercise is better for maintenance as opposed to actually directly for weight loss. And weight is such an important topic. I think that was some of our most favorite podcast of last season, had to do with superfoods and had to do with weight loss. I'd like to now shift to wrapping things up and talking about staying healthy. I think from a brain perspective is using both the left and the right side of your brain. And I think you have done that exceedingly well, working in science during the day, and you're very creative and like to write and read. Tell us a little bit about what you do in your personal time and all your reading and all your writing and giving book reviews, and how you started on that.
Sure. Well, I started doing book reviews on a platform called Goodreads, which is, I believe now a subsidiary or owned by Amazon. And it's just sort of a social media site for people who are bibliophiles. And you can track your reading. That's what I found it really effective for, is like, I want to remember what books I read over a given year, along with, setting goals for the books that I want to read, and then, be able to take notes and sum up my thoughts after I did the reading. So I was using that platform for a long time, and I also became aware of Substack, which is, sort of a blog platform. And I just a lot of times would expand my book reviews on Substack that I was initially doing on Goodreads. And I've been doing that for a couple of years now. And I really enjoy it. I mean, I think it's always important to be a lifelong learner and to continue to use your brain. I mean, a lot of the longevity research would suggest that, people who are staying active, not just physically, but intellectually, mentally, socially, are able to, live longer. There's some debate, whether that's...
And reduce the risk of dementia, which is a particular problem for older individuals.
Certainly. So I just, want to continue to maintain my... maintain the use of my brain, of course, not just in, my job, but outside of my work as well. And so I try to read as much as possible. Both I'm a fan of audiobooks, but I also read ebooks and hardcover books as well. And I don't ever want to forget anything I've read or learned, so I try to turn that into reviews and notes and so on. And so I use the Substack platform and platforms like Goodreads to do those things, and
you've written
get a lot out of it.
You've written two Substacks. You have a science one and then a literature one.
Yes. And
talk about why you separated the two and some highlights from both of those Substacks.
Certainly. It's all under one Substack technically, but I've essentially two channels, and one of the channels follows my science writing, and right now I wanted to do some focused scientific writing on cancer genetics or cancer genomics, whichever term you would like to use. And I've been, I think I have almost 10 different essays or small posts on different cancer syndromes. Of course, starting with the one I did my PhD work on. And, I try to post those regularly, about like once a week. And I want to be able to get through all of the known cancer syndromes, and then do some commentary on the state of precision medicine, which is, largely composed of precision oncology. And then the other side of things is, the books that I read for fun, that I would just, want to continue to share my thoughts on. And so that's what the remainder of what I post on my Substack mostly is.
And you're a great fan of reading great books and fiction. Mm-hmm. You also read some nonfiction too. And yes. I've heard you make comments that in general, if women read fiction, a lot of them like historical fiction. And I find your science Substacks interesting in that you make a historical references, of course, to the history of the science as well.
Yeah, my comment was probably more along the line that, like, when people read for fun, the sex breakdown typically is that women often read fiction books and men often read nonfiction books. It's funny in my household, actually.
I thought it was
my wife
reverse.
Much prefers No. Well, maybe it is for you, and that's
right.
Certainly how it is for my wife. But the surveys or the whatever they found suggest the opposite, that it's mostly fiction. I mean, at least when you're in these, communities of book readers and so on, that the experience of what you see, it does seem to break down that way. It's funny how much of a divide there is often between the people who read nonfiction or fiction. There aren't too many who seem to like to do both. So I guess I sit at the kind of the interface between these two different groups. I love reading both nonfiction and fiction books. Actually, recently I've been reading a lot more nonfiction, but versus growing up and doing an English major in college, which is, is essentially almost, all fiction, or at least you're reading literary criticism about fiction. So right now it's like an 80-20 breakdown or something like that for me in terms of nonfiction to fiction, but, relative to, what maybe the median reader does, it's probably a lot more fiction books a lot of the time. It's unfortunate that we kind of have a culture where, we have so many options in terms of entertainment that a lot of times we turn away from kind of the older school version where we're reading words on a page. So
yes, I do some audio books and some ebooks, but I still really like the old fashioned holding the book and sitting down and getting in a comfortable chair and reading. Mm-hmm. And I think that that's good for the brain and should be encouraged. Any comments about why fiction is so important and why stories and narratives maybe help people process their life or be mentally and emotionally healthy?
Certainly. There's actually like a sort of a scientific debate about like what the purpose of storytelling or what the purpose of fiction is. And, one of the conclusions, there's many different theories about it, of course, but one of the conclusions is that it's sort of a vicarious learning mechanism. Mm-hmm. So you, by reading, get to learn what it's like to be in the mind of, not only in the mind of someone else who is you or potentially is nothing like you whatsoever, but then get to game out the experiences of the protagonist or the antagonist of the story. And if I was in this extreme situation, what would it be like psychologically, emotionally? What would you do? So it's this vicarious learning, which, someone who's familiar at all whatsoever with like the evolution of the brain or just neuroscience in general, one of the special things that organisms with big cortexes do is basically model future events. So they can learn without having to just do the trial by error of actually doing something. They can learn by envisioning a possibility that isn't there. And so fiction is, in some ways, maybe a crutch where you don't have to actually do the brain work of inventing something all by yourself. You get to see what someone else has invented and go through that vicarious learning process.
Well, this is also interesting. We'll have to have you back to delve more into that. Thank you so much, Dr. Stetson Thacker, for joining us on this podcast talking about cancer genetics and talking about literature and health and fitness and keeping our New Year's resolutions. That's certainly something I think the female brain does, is multitask. I know sometimes I drive you crazy when I jump topics, but we want to fit it all in for our listeners to live our mission of being strong and being healthy and being in charge. And if you would like to not miss an episode of our podcast, please subscribe to our Speaking of Women's Health podcast on Apple Podcasts, Spotify, TuneIn, or wherever you listen to podcasts. And thanks to you, our loyal listeners, for tuning in. And if you've enjoyed this episode, leave us a 5-star rating. Share it with friends. And thanks again. And I look forward to seeing all of you next time in the Sunflower House.